Okay, we've fixed our technical issues. Now we can start. Um, so before I begin, I just want to acknowledge the board members in the room: Director Tendra Balin, Director Zhao, Councilor Perks, Deputy Mayor Malik, Councilor Bravo, and online we have Director Singh, Director Roy, Councilor Thompson, and Deputy Mayor Morley. So the board secretary will advise. Well, nope, that's not good. So good morning, my name is Councilor Chris Moyes, and I am the chair of the Board of Health. The board secretary has confirmed that we have quorum, so I'll call meeting 11 of the Board of Health to order. And welcome to everyone. Today's meeting is being held with board members and city staff participating both by video conference and in person at City Hall in Committee Room 1. City Hall is open to the public and anyone is welcome to attend the meeting at City Hall today. The public may continue to participate electronically by video conference. This meeting is also being live streamed online at youtube.com/Toronto City Council Live. I ask everyone for their patience with any delays and technical issues. The city's staff, the clerk staff will connect all remote registered public speakers to the meeting by audio. The list of speakers can be viewed online by visiting the Board of Health's page at toronto.ca/council and clicking the speakers box for today's meeting. The board secretary has also emailed the speakers list to directors. Directors, this is a paperless meeting. The board secretary has provided all agenda material on toronto.ca/council and via CMP, the clerk's meeting portal. Directors, please keep your mic muted unless you wish to question staff or speak to an item, and ensure that your video is turned on. As part of each agenda item, I will ask directors to raise their hand or unmute their mic if they wish to question staff or speak. I will then create a speakers list and will call on directors when it is their turn to speak. When voting on an item or a motion, I ask that directors ensure that they turn on their video and to raise their hand to indicate their vote. Directors, I want to remind you that you must submit and approve your motion by email. Staff are available at boh@toronto.ca to help with motions. And Trustee Shrishkan Raja has joined us here as well. The Board of Health acknowledges the land we are meeting on is the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work and live on this land. As public health professionals and members of the Board of Health, we recognize the historical and present-day traumas inflicted upon Indigenous peoples. We stand with communities and families as they mourn the loss of loved ones who were sent to residential schools and never returned. We also acknowledge our complicity in ongoing colonial violence. We commit to supporting the efforts of Indigenous groups towards reconciliation and action-oriented practices, including the equitable use of resources. We strive to learn Indigenous histories and collaborate with communities and families so we can create safe spaces that honor Indigenous cultures and ensure that Indigenous perspectives are present in our work and practices. As a Caribbean Canadian, I am committed to continually acting in solidarity with our African, Caribbean, and Black communities, seeking freedom and reproductive justice in light of the history and ongoing legacy of slavery that continues to impact our communities across Canada. As part of this commitment, I would also like to acknowledge that not all people came to these lands as migrants and settlers. Specifically, I wish to acknowledge those of us who came here involuntarily particularly those brought to these lands as a result of the transatlantic slave trade and slavery. In support of the City of Toronto's ongoing efforts to confront anti-Black racism, I pay tribute to those ancestors of African, Caribbean, and Black origin and descent. Are there any declarations of interest under the Municipal Conflict of Interest Act? If you have an interest, please raise your hand and unmute your mic and indicate the item number and the nature of the interest. Seeing none. Next, we need a motion to confirm the minutes from our board meeting on February 12th, 2024. Director Sandra Ballin, all those in favor? Opposed? Carried. I will now move on to my remarks for this month. As the first quarter of the year ends, we reflect on the work of Toronto Public Health in 2023, as presented in our Year in Review report. As Chair of the Board of Health, I am proud of the work we achieved last year. Together, we took significant strides in 2023, reinforcing important partnerships, focusing on health equity, utilizing data to guide decisions, and reinstating key public health programs that were interrupted by the pandemic. The knowledge gained from last year's experiences will help inform the development of Toronto Public Health's new strategic plan. The results from the Board of Health's 2024 self-evaluation were also insightful, and thank you to all who participated. These results will aid the board in clarifying roles, improving internal relations, and enhancing our processes for information sharing, decision-making, and planning. Toronto Public Health continuously tracks health trends and acts proactively, but sometimes unforeseen challenges emerge that demand quick action. Last year, we experienced unusually high levels of wildfire smoke, affecting air quality in Toronto and across the country, leading us to develop the wildfire smoke response strategy. Let's not forget, climate change is a public health issue. As we leave behind a very dry, warm winter to usher in spring and summer, we are prepared for a potential repeat of last year's wildfire smoke with comprehensive communication and impact mitigation strategies. Another issue that has been top of mind for Toronto Public Health is the recent uptick in measles cases in our city and province, which we will receive an update on today. While it may be concerning to see cases popping up, it is important to remember that vaccinations do work. With the widespread uptake of 2-dose vaccinations, Canada and the United States were able to eliminate measles. By ensuring that we and our loved ones are up to date on our immunizations, we not only protect ourselves, but we also contribute to the collective health and safety of our community. I would like to take this opportunity to urge residents, especially those who have upcoming travel plans, to ensure they are up to date on their measles vaccines. Recently, Toronto Public Health has raised the alarm on an uptick in suspected opioid overdose-related deaths. While there is currently no additional information on the drugs connected to these deaths, Toronto Drug Checking Services has recently identified 2 high-potency synthetic nitazene opioids in Toronto's unregulated opioid supply that can be up to 20 times as potent as fentanyl. With this high potency comes an increased risk of overdose. However, overdose-related deaths are preventable, and harm reduction services in the city, including safe consumption sites and drug checking services play a crucial role in preventing these deaths. One of the key items on today's agenda is to formally transition from the Toronto Drug Strategy Panel to the Our Health, Our City Implementation Panel. This will advance our mental health, substance use, harm reduction, and treatment strategy for Toronto and allow us to bolster our response to these challenges. A big thank you to all the members who served on the Toronto Drug Strategy Panel. And also thank you to Deputy Mayor Malik and Upala Chandrasekhar for leading that work, as well as the work you put into transitioning and establishing the framework for the Our Health, Our City Implementation Panel that will be discussed and voted on today. As we look forward to the future, let's draw strength from our achievements and the vital work we've started. Our commitment to public health, the resilience we've displayed in the face of challenges, and the strides we've made together give me confidence and optimism in our ability to continue serving Toronto in the best way possible. Let's continue to work hand in hand for healthier and safer Toronto. And before I hand it over to Dr. Davila, our Medical Officer of Health, just want to mention that we will take a pause or a recess, a short recess at 10:50 for a photo. The Lieutenant Governor is in the building and councillors are to take photos with her. Okay, I'll pass that over to Dr. Davila. Go ahead.
Thank you, Chair Moyes, and good morning, members of the Board of Health, those of you that are gathered here in the room, and of course, those of you who are joining us online. As already touched upon by the Chair, based on his recounting of the many activities that go on in public health, it has been an extraordinarily busy month since we last gathered together in this room and online for this meeting. It has been covered indeed in the media, a number of the stories and issues on which we're working at Toronto Public Health. We have seen, for example, an increase earlier this year in respect of Mpox cases. We've been incredibly busy with vaccination campaigns, yes, for Mpox, but as well for measles, for our school immunization program, for the immunizations involved in the Immunization of School Pupils Act, and as well, we still had some activities going on in respect of our COVID and flu vaccination campaigns, which just recently came to an end. And of course, as the Chair mentioned, as is the case in many other places around the province, around the country, and indeed around the world, we have been dealing with some measles cases as well. And there's no question that even with a few measles cases, as in any communicable disease investigation, there are a number of steps involved, and they do keep many parts of our organization quite busy. You will hear a little bit more in today's meeting around a measles update. But again, just to give you a little flavor as to what's required within the context of a measles or communicable disease investigation, it starts off with a case being reported from a health provider who suspects measles and reports it to us as the local public health authority. There's, of course, an investigation process where we find out more details in respect of the case, things like symptoms, travel history, and vaccination status. Testing is required in the transportation of those samples for appropriate testing to confirm a diagnosis. And then, assuming a diagnosis is confirmed, there is a whole process involving contact tracing, in some cases follow-up, quarantine measures to prevent the ongoing transmission of measles as much as is possible, and of course monitoring both of the individual who has the confirmed measles case and those who might have been exposed. I can readily explain those to you in just a few seconds here around a table, but of course the actual work that's involved in undertaking that investigation and all the follow-up steps requires dozens of people, again, depending on the size of the situation, and many, many hours of work. So my gratitude to all those in our organization who've been involved in the response to date. Finally, I would be remiss if I didn't talk about, at least very briefly, there are, of course, dozens of other public health programs that go on a day-to-day basis in order to meet the diverse public health needs of Toronto's population. And as I always try to do, my thanks goes out to the entire team at Toronto Public Health, those who are working on those issues that clearly make the media, and those who are working on those issues that are equally important but don't necessarily make the front page or the news coverage. My thanks goes to the entire team at Toronto Public Health for the work that they do every day in service of the population of this city. With that, Chair, I'll turn it back to you, and thank you for the attention and time.
Thank you, Dr. Davila. So we'll now review the agenda. So item HL 11.1, 2023, a year in review for Toronto Public Health. There is registered speakers on this item, so I will hold it down. Item HL 11.2, Toronto Public Health update on measles prevention and management. There's a staff presentation and there are speakers on this item as well. Item HL 11.3, implementation of panel for our health, our city, a mental health, substance use, harm reduction and treatment strategy for Toronto. There is a presentation, but there's also one speaker on this item as well. And the last item on the agenda is item HL 11.4, 2024 Board of Health self-evaluation. Anybody want to hold this item, or we could, you want to hold it? Okay. Okay, no worries. Okay, so Councillor Bravo will hold down item HL 11.4. All righty, with that, we'll go back to item HL 11.1, 2023, a year in review of Toronto Public Health. Dr. Davila, you can go ahead and introduce any.
There's no introduction here. I think you're going to speakers, your deputation.
Okay, just deputations, okay. Jeffrey Goodman, are you here? Okay, you have 5 minutes to present to the Board of Health.
Well, good morning. Today I want to discuss what evidence you use to inform your decisions. You deliver evidence-informed decisions, and your decisions are informed by accurate, timely, and scientific information. And as a Toronto public health organization, I assume you take guidance from the public health authorities in Canada, and I expect you would be hard-pressed to not follow their recommendations or advice. But as an autonomous body of Toronto municipal government, it is your responsibility to practice due diligence when making your recommendations. I would submit that just following the directions and advice of other organizations does not meet the standard of due diligence. You must do your own research and exercise your own critical thinking to make sure you are basing your programs on the latest accurate scientific information. I believe this means questioning whether the health authorities ever get it wrong. There are numerous examples of the authorities getting it wrong. In the 1950s, DDT was advertised widely as being safe and effective and was liberally sprayed in many population centers. Lead in gasoline and smoking were long considered safe, yet after many years, their negative long-term effects became widely known. There have been specific pharmaceutical products that were introduced as being safe and effective, but were later found not to be safe, but dangerous. Thalidomide is an example of a drug that was approved by Canadian authorities, but was later withdrawn because of the deformities it caused. It was effective in stopping morning sickness, but it was not safe. A similar experience happened with Vioxx. Vioxx was approved as safe and effective painkiller. It became one of the world's best-selling painkillers. 5 years after its launch, Merck withdrew Vioxx from the market after a study showed Vioxx caused an increased risk of serious cardiovascular events such as stroke and heart attack. This leads to our current situation regarding the COVID-19 vaccine and giving it to children. Canadian authorities say it is safe and effective. Does current research support this statement? I suggest there is sufficient evidence to make one question its safety and effectiveness. Also, one needs to remember that a drug can be effective but not safe, as was explained in the previous example of thalidomide and Vioxx. A study by the Canadian Pediatric Surveillance Program has shown that children, particularly preschool and school-aged children, that were at low risk of severe COVID-19 disease in the first part of the pandemic, it was the largest study of hospitalized children and youth infected with SARS-CoV-2 in Canada. An analysis published by the CDC reaffirms that it is very uncommon for children to die from COVID-19. The British Medical Journal in January 2023 stated, "Since the beginning of the pandemic, it's been clear that children are far less at risk of severe disease from SARS-CoV-2 than adults. Incidents of critical COVID-19 in children remain rare, even though the Delta and Omicron variants have proved considerably more adept at infecting children than previous variants." This now raises the question as to whether it is prudent to impose COVID-19 vaccinations for children. The journal Immunity, Inflammation, and Disease is a peer-reviewed immunology journal. In their March 2023 edition, they published a study titled Adverse Events Following COVID-19 mRNA Vaccines. The adverse cardiovascular events were pericarditis, myocarditis, hypotension, hypertension, arrhythmia, cardiogenic shock, stroke, myocardial infarction, intracranial hemorrhage, deep vein thrombosis, cerebral venous thrombosis, arterial or venous thrombotic events, portal vein thrombosis, coronary thrombosis, microvascular small bowel thrombosis, and pulmonary embolism. In fact, according to VAERS, there are more adverse events reported about the mRNA vaccines compared to all other vaccines combined over the past 30 years. The National Health Services in the UK has stopped giving COVID-19 vaccines to children. England, Finland, and Norway have stopped short of recommending the vaccine for healthy children. Currently, the COVID-19 vaccine isn't part of the Ontario immunization
Final
schedule.
thoughts, please. Your final
I
thoughts.
believe there is sufficient evidence to not impose the vaccine on children and let parents decide what is best for their children. Thank you.
Any questions for the deputant? Seeing none, thank you for coming in today. Next person is Skylar Hill Jackson. Are you here? Okay, you have 5 minutes to present to the board.
Thank you. May I have the overhead turned on, please?
Yes, staff can see. Here we go. You have 5 minutes.
Thank you. The Toronto Board of Health 2023 Year in Review states that promoting the health and mental well-being of youth and students in schools was a significant area of focus, and vaccination is one of the most effective public health interventions. As a parent and grandparent, it is my opinion that the Toronto Board of Health's key priority moving ahead with your strategic plan 2024 and beyond is to stop bullying parents into providing their child's vaccination status to Toronto Public Health and to remove vaccination clinics from all Toronto schools. Toronto Public Health must take the $3.8 million from the province earmarked for vaccine uptake and put those precious dollars into building a child's healthy immune system through nutrition and lifestyle initiatives. With the 75 doses of 18 vaccines recommended for my 5 grandchildren and the declining health of Toronto children, the decision to vaccinate or not is one of the most important decisions a responsible parent is required to make. Vaccines are complex biochemical substances that by definition are drugs. Once injected, these vaccines can cross the blood-brain barrier and cannot be deactivated or removed. Multiple vaccines in one shot have never been safety studied. Excessive vaccination has never been safety studied. Where is Toronto Board of Health's guiding principles of health and community safety for everyone? Where is the Toronto Board of Health's ongoing monitoring, evaluation, evidence, innovation, and continuous improvement? Where is the board's foundational principles of accountability and transparency? Can the Toronto Board of Health members prove that the use of vaccination has not inadvertently created more serious and chronic illnesses? This is the rate of serious illness in children today. ADHD, 1 in 10 children. Learning disability, 1 in 6. Juvenile diabetes, more than 100% increase since 1980. Allergies increased 6 times since 1980. Obesity has tripled since 1980. Mental illness in 1 in 30 children. There is a dramatic increase in childhood cancers. Anaphylactic food allergies doubled in the last decade. Eczema, 1 in 5 children. Asthma, 1 in 8. Seizure disorder, 1 in 20. Autism, 1 in 36 children. And SIDS is the leading cause of infant death. We are experiencing a major epidemic of neurological and immune system disorders common in Toronto children today. In the meantime, CBC and Toronto Board of Health are hysterical about a few measles cases. Should the 46,000 Ontario children on the autism spectrum be considered an epidemic? When will the Toronto Board of Health show us the science that proves that the use of vaccination has not inadvertently created even more serious and chronic illnesses in Toronto children? To help Toronto parents with the question of to vaccinate or not to vaccinate, there is a new book, Vax, Unvax, Let the Science Speak. This new book cites over 100 peer-reviewed studies. Guess which group is healthier? No guesses? The contrast is stunning, with the unvaccinated children having little or none of the chronic illnesses that I have just listed, while these chronic illnesses are skyrocketing amongst vaccinated children. Let's take the money that is poured into vaccination campaigns and use it for measures that we know support healthy children and will never contribute to causing any of the chronic conditions I outlined. Let's provide more access to fresh fruit, vegetables, and healthy food, particularly for food insecure communities. As for vaccines, let us call our own shots. Warning, this deputation may require thinking for yourself. Ask your doctor if thinking for yourself is right for you.
Okay, thank you. Any questions for the Deputant? Seeing none, thank you. Next up is Mariko Uday. Are you here? Okay, you're online, I was informed. Are you able to unmute?
Yes.
Okay, here we go. You have 5 minutes to depute before the board. Go ahead.
Good morning, board members. Today, I would like to submit a request for your consideration prompted by the Toronto Public Health Year in Review 2023 report. And it has to do with the Toronto Population Health Profile 2023. Under theme 3 of the Year in Review report, it says leveraging data, and it says Toronto Public Health released the Population Health Profile, and this report provided critical insights into local health trends. It guides TPH's efforts to address emerging health needs. So when I read that, it makes it sound as if the Toronto Population Health Profile provides critical up-to-date data. And the actual population health profile itself says, after 3 years of living with and responding to a pandemic, this profile provides the most current health status of our city. So I expected to find there data on changes in disease trends and mortality rates throughout COVID-19 in order to assess the impacts of the pandemic. The pandemic was a great time, well, not a great time, sorry. It was a time of great upheaval. It has changed physical, mental, and social health patterns and mortality. We need to leverage data, as you say in the Year in Review report, to figure out what happened. As a member of the public, I would like to request for up-to-date mortality data by cause to be added to the population profile or some other addendum report so that it can truly provide critical insights as described in the Year in Review 2023 report before us today. It is not out of place to add this mortality data because this has been done in the previous population health profile of 2019. And I know that this data is available up to 2022 because it's available on StatsCan's website. And what is puzzling, well, the StatsCan data has provincial and federal level data, but that means there must be local data feeding into it. What is puzzling and concerning is that in both Ontario and in Canada, the mortality rate of the 3 years, 2020, 2021, 2022, has been the highest in 2022. Why is this? And what is the status of Toronto? That's what I would like to know. As it says in the population health profile, updating city's understanding of Toronto's health status is an important step toward assessing the impacts of the pandemic on the city's well-being and will inform future strategies and decisions to improve the health of residents and to reduce health inequities. In the year in review report before us today, it has under theme 3, like a little mention of Toronto's population health profile, and it has a graph showing Toronto's population. But what I would like to see is something more substantial than just the population trends of Toronto, but like data on mortality and changes in disease patterns and so on. Thank you.
Thank you. Any questions for deputants? Seeing none, thank you for coming in today. And the last speaker on this item is Laura Repo Davis. Are you here? Okay, you have 5 minutes to depute before the board.
Okay, hello everybody. I like the current vision of Toronto Public Health, a healthy city for all, but it contrasts sharply with the last 4 years, which felt more like an angry city for all. This is what I want to address today. A new strategic plan desperately needs to consider not only the last year, but the last 4 years, which happens to encompass the COVID-19 crisis, perhaps the biggest public health crisis in history. It might warrant a review and some deep questioning over TPH's role in COVID-19 policy. Without it, we are bound to make the same mistakes. My honest assessment, and I realize I'm not a public health expert, is that COVID-19 was a public health catastrophe. I say this not to diminish those of you at the helm who were tasked with a very difficult job, but rather to normalize this conversation. I think it should be okay in a liberal democracy to have questions and to disagree. It only makes us smarter when we look at all sides of a complex crisis. Was public health's approach to COVID a reinvention of the wheel? Did COVID policy make things worse? Was the harm inflicted on people from lockdowns, school closures, and mandates, and the ensuing demonization and exclusion of a segment of society something that we could have avoided? This is also not to diminish the seriousness of COVID for those who suffered through it and died. But COVID-19 is an age and disease stratified illness. Not everyone was equally vulnerable. But the public health approach assumes that everyone was equally vulnerable and at the same time equally capable of restricting their contact with society, something that caused immense harm. I think of children and youth at the top of this list. School closures were a shameful failure of the COVID response, and children are still catching up. My question has always been, was the correct risk-benefit and cost-benefit analysis made when it came to COVID-19? What about the principle of not making the situation worse than the disease itself? Isn't that a basic public health practice? I'm drawn to the wisdom of the Hippocratic Oath that says, first do no harm. This should be a guiding principle for every future public health policy, especially in an emergency. The harm that stands out, and there's much to cite, was the 2021 COVID-19 vaccine rollout, which shape-shifted into the so-called pandemic of the unvaccinated. I was surprised that TPH didn't intervene in the demonization during that time. It would have been easy to step in and calm the hate speech because everyone said they were following public health. The demonization came from many fronts: the angry mob on social media, mainstream media, almost every politician, including our Prime Minister, Justin Trudeau, who threatened the unvaccinated by saying they would suffer the consequences. There is a difference between a vaccine policy that compels and a vaccine policy that coerces and condemns.
COVID-19 health policies generated powerful propaganda that caused intense division. I lost friends during this crisis just for having a critique of what was being done in the name of safety. I lost family connection, which is still being repaired. My mental and physical health deteriorated. I feel like I'm recovering from PTSD, and I'm not alone in this experience. These are all relevant health outcomes. COVID policies also resulted in social upheaval and legal battles, some of which are still taking place, and that impacted the City of Toronto too. Was this an effective path to health and safety? I would suggest COVID-19 have its own category in the upcoming strategic plan and a longer intake period for community engagement. Take adequate time to examine mistakes that were made before moving on. Toronto could be at the forefront of transparency and dialogue in reviewing COVID policy, examining other jurisdictions like Sweden, who chose a different route and fared much better in terms of reducing unintended consequences. Let's review pre-COVID pandemic policy that wasn't followed and ask why. Was a virus politicized? Was there an overreach of power? Was there an over-reliance on modeling versus real-world data? Did the one-size-fits-all COVID measures create unnecessary harm? We could correct and update information and educate ourselves. The result might be some healing for the people of Toronto, especially with an apology to those who are the unintended victims of COVID policy. Hopefully, the inclusion of the Indigenous cultural safety principles of respect, truth, humility, engagement, and reciprocity could be used to weigh the impact of COVID policy while still moving ahead
Final
with a
thoughts,
new
please.
strategic plan. This would be a breath of fresh air and a profound step towards a healthy city
Thank
for
you.
all.
Any questions for the deputants? Seeing none, thank you. We do have one more item, one more person on this list, Therese Dineen. Are you here? You have 5 minutes to depute before the board. Go ahead.
Can I get the overhead, please?
Just put your item on.
On the City of Toronto's website, there's an article titled "An Infectious Idea, Prevention of Communicable Diseases." The article reads, "Before antibiotics, the only way to recover from tuberculosis was to strengthen the immune system with plenty of rest, nutritious food, and fresh air. The knowledge and guidance provided by the city recognizes that supporting our natural immune system effectively supports good health, a practice that still makes sense today. During the COVID-19 years, it's unfortunate that information about how to naturally strengthen our immune system was censored, and many health practitioners had their social media platforms removed. What happened? What happened was a declared pandemic by the World Health Organization and an emergency use authorization for a COVID-19 vaccine. Your review of 2023 acknowledges that COVID-19 highlighted the need for more effective public health communications. I'm hopeful that the serious safety concerns raised by Toronto citizens regarding COVID-19 vaccines will lead to a new understanding by the Board of Health, and that new approaches to strengthening immunity will be implemented in the new strategic plan. To reiterate two concerns expressed by Torontonians related to the COVID-19 vaccines: they're not safe and they're not effective. First, COVID vaccines are not safe. Data from the American VAERS Vaccine Adverse Event Reporting System indicates there are more than 1.6 million reports of adverse effects and more than 37,000 deaths, including children. It's additionally alarming that a Harvard study for the US Department of Health found fewer than 1% of vaccine adverse events are reported through the VAERS system. Are you aware that Torontonians are now receiving the non-mRNA Novavax vaccination, and that data from clinical trials and post-safety monitoring suggest an increased risk of myocarditis and pericarditis following this vaccine? Second, the COVID vaccines are not effective. Studies indicate the immune function among the vaccinated individuals after 2 doses of the vaccine was lower than among the unvaccinated individuals. Toronto Sick Kids Hospital issued a guide titled "Myocarditis and Pericarditis after mRNA COVID-19 vaccination in children." During this same period at Toronto City Hall, vaccine clinics were set up and children were enticed with free ice cream to get their COVID vaccine to protect against an illness they were unlikely to be affected by. If there is a benefit to the COVID-19 mass injection campaign, it's that more Canadians are critically thinking when assessing the need for all vaccines. In fact, at the Board of Health meeting in November 2023, Dr. Lemke indicated that there are more than 250,000 students who are missing doses of vaccines. She said, "We know the pandemic experience has changed people's perceptions of vaccination, and it's probably going to take more considered slow effort to build trust." Doesn't building the trust of parents in relation to safety concerns include acknowledging all medical and scientific data, as well as respecting the health decisions made by families? Did you know that mercury and aluminum are still in some vaccines? Did you know that the association between mercury and aluminum adjuvants and autism spectrum disorder is suggested by multiple lines of evidence? The Government of Canada recognizes that about 1 in 50 Canadian children are diagnosed with autism spectrum disorder, an increase by over 500% since 1990. Did you know that food protein is in vaccines? It was demonstrated over 100 years ago that injecting a protein into humans causes immune system sensitization to that protein. Subsequent exposure to the protein can result in allergic reactions and anaphylaxis. At the February 2023 Board of Health meeting, Dr. Finkelstein explained how the Board of Health receives direction from World Health Organization during health emergencies via information from federal and provincial colleagues. At this same meeting, Dr. Davila indicated that Toronto Public Health operates with public funds. Therefore, the Board of Health is accountable to the public in protecting the public's health. Toronto Public Health and the Board of Health, please acknowledge and inform your provincial and federal counterparts that many Torontonians will continue to rely on the wisdom of truly safe and effective natural forms of healthcare for their well-being and the well-being of their families.
Okay, any questions for the deputy? Seeing none, thank you. And that was the last on the speakers list. Directors, any questions to staff? Councillor Bravo?
Thank you, Chair. On a different topic, there's been a lot of work that's been done in the last year, a lot of attention in the city to the public health crisis of homelessness, and I was hoping that someone could describe a little bit of the work that's been undertaken thus far by the Health and Homelessness Working Table in relation to our look back at Toronto Public Health.
Sending it over to staff to answer.
Thank you.
Thank you, Councillor, for the question. Through the chair, we have had several meetings with the homelessness and housing and health table, and at each meeting where the community partners have gathered has been on a different topic, and we are planning to come back to the board with the update after our final meeting, which is happening, I believe, within a month's time.
And certainly one of the accomplishments of the last year has been to change the threshold, which has been done at Toronto Shelter Services and Support. So now we're opening warming centers at -5 as opposed to -15. And I know that's a conversation that started here at the Board of Health, so thank you.
Any other questions for staff? Okay. Guess I'll have one. I'll take a stab at it. Partnerships. I know we talk about various communities here in the city of Toronto, seniors, women, people of color, and disabled people. But we know that our city doesn't have physical boundaries. How do we work in partnerships with other regions, GTHA communities around some of the issues we're dealing with here in Toronto?
So through you, Mr. Chair, we are in regular conversations, certainly with public health partners all around the Greater Toronto and Hamilton area. We have a number of tables where we confer with our partners, from different jurisdictions so that we can coordinate as much as possible and understand what's happening in the jurisdictions surrounding us on many of the key issues that clearly impact on the health, yes, of Torontonians, but there are many issues that we share in common with those jurisdictions around us. Those are at least monthly, if not more often, conversations, and we certainly do work, as do many other health system providers, on a number of issues in common.
And some of the deputants alluded to the idea that we did not examine data appropriately, or that we as a city in public health don't have the best interests of the community in the way we do our work. How do you respond to that?
So through you, Mr. Chair, there's no question that our goal at Toronto Public Health, I've said in front of this table many times, and I will continue to say it again, our main objectives are to improve the health status of the population, to reduce any inequities in health status, and to ensure as much as possible that we're prepared for and able to respond effectively to outbreaks and emergencies. That's the core of what we do at Toronto Public Health, and I would dare say that's what the entire goal of the public health sector is. So clearly, there are other partners that we engage with, yes, at the provincial level, yes, at the federal level, and as you heard and have heard many times at this table, there are international health partners with whom we confer. Those data come to us through our federal and provincial partners. But there is a shared interest in ensuring that the health of the population that we serve here locally is actually optimized as much as possible. And yes, that includes a very important focus on addressing health inequities and reducing those as much as is possible, using the best available data, using the best available science, and ensuring that it is consistent with what makes sense for our local circumstances.
Thank you. Those are my questions. Speakers on this item?
Mr. Chair, Councillor Thompson here. Question, please.
Go ahead, Councillor Thompson.
Thank you very much, Mr. Chair, and good morning. Through you to Dr. Davila. Dr. Davila, thank you so much for the report and the presentation. You spoke about improving the health and obviously the stages to help the population. I am consistently being told by members of the Black community, particularly Black women, that there is a major difference with respect to how they are being treated in the health system. I wondered whether or not you have any comments, or are you aware of the differential concerns that many in the Black community, particularly Black women, have with respect to the system?
So through you, Mr. Chair, thank you, Councillor, for raising this issue. There is no question that racialized groups and racialized women in particular do face some challenges within access to care in the healthcare system. As you know, as local public health, and we know that they have differential outcomes as well. We liaise regularly with our partners in the healthcare system. We actually don't have purview over that which happens within health care per se, but we do liaise with those partners regularly, and certainly we have worked with a series of groups to try to address some of the access issues and to address some of the disparities that we actually see in terms of health outcomes. We can only, we focus obviously first and foremost on those areas where we have direct control as local public health, but that certainly doesn't stop us from speaking with our healthcare partners on those areas over which we do not have direct control. I think I would also be remiss if we didn't speak about the fact that many of the health differences that we experience in our community are not just about health care, but actually the social determinants of health that are far outside of the realm of health care. Things like housing, things like income. These are issues that clearly have very significant impact on the health status of the entire population, and specifically have differential impact on those who are racialized in our community.
Thank you very much for that. Dr. Davila, in light of the comments by speakers this morning on this particular issue, I wonder if you could help us to understand how jurisdictions around the world have dealt with the issue of vaccination, particularly for children.
So very briefly, through you, Mr. Chair, we know that actually vaccine has been one of the major accomplishments of the last 100 years in public health. Literally, thousands and thousands and thousands of lives have been saved, and much preventable illness has been avoided as a result of vaccines. We don't have enough time here to get into a whole history, but it is one of the most significant accomplishments of public health. So we know that there are processes, and we've discussed those processes here at this table many, many times in respect of vaccine. There are very strict processes that need to be followed at the federal level before vaccines are made available for use in the public. But I can tell you that whether we're looking at measles or the series of vaccine preventable diseases, we have seen significant decreases and significant benefit. Children who did not survive before are now alive and well, yes, in this country and in countries all over the world, thanks to vaccines. So there's a lot of science behind this. There are reasonable questions that people can ask, and I think that when it comes to having conversations around vaccination in children, the science suggests that the best conversations actually happen between parents, families, and their own healthcare provider, where you have a relationship of trust. We provide some information in general, but specific decisions and specific conversations best occur within the context of clear trust and knowledge between a healthcare provider and the person in question.
Thank you very much, Dr. Davila. Thank you, Chair.
Thank you, Director Thompson, for the question. Speakers on the item? Okay, seeing none, I will say a few words. I want to thank Dr. Davila and her team, and to all the directors here today around this table. We've done a lot of great things together this past year, which I'm very, very proud of. Yes, there's been challenges, but there's been many successes as well. So, and that's what Board of Health is all about, right? Challenges continue. But I'm confident in the team that we have here. So thank you once again. I'm gonna ask Dr. Zhao perhaps to move this item, if you're okay with that. Okay, all those in favor? Opposed? Carried. Thank you. The next item is item HR 11.2, Toronto Public Health, update on measles prevention and management. We do have a presentation on this item. I'll ask Dr. Davila to introduce the members.
So thank you, Mr. Chair, and we are joined for this presentation by our two Deputy Medical Officers of Health, Dr. Michael Finkelstein and Dr. Anakashi Lemti. So I'll turn it over to them.
Good morning. Thank you for the introduction, Dr. Davila. Next slide, please. Measles is a highly contagious viral illness that is transmitted through the air very easily between susceptible people when they cough, sneeze, or even breathe. You can see the typical signs and symptoms on the slide associated with being infected with measles, which can lead to complications such as a brain infection, pneumonia, particularly for young infants and pregnant people. People can transmit the virus from 4 days before to 4 days after the rash appears. Also, the virus can remain suspended in the air for up to 2 hours after an infected person leaves a room, placing others who enter at risk of becoming infected, which is why the virus is so infectious, and one person can, on average, infect 9 susceptible people around them. However, measles remains uncommon in Toronto, but the risk of an outbreak is now higher due to an increase in international cases, which can be imported, and the reduction in vaccinations due to the pandemic when access to healthcare was impacted. Toronto Public Health has already detected measles cases linked to travel in 2024. Next slide, please. Toronto Public Health has a central role in the investigation and public health management of measles cases when they are detected. Our most important roles can be broken down into those associated with the person who is infected and also roles involving those who have been in contact with this person. For the case, Toronto Public Health ensures that there is appropriate testing to confirm that this is measles, as the signs and symptoms are not specific for measles and can be caused by other viruses. Then we ensure that the person who is infected is isolated to reduce or eliminate the potential for further spread. We consult with others, such as the Ministry of Health and Public Health Ontario, on the response, as these cases are uncommon. For the people who are in contact with this infected person during the period when they could have spread the infection, we identify those individuals and ensure that they are aware of their exposure and can watch for signs and symptoms of illness and check their vaccine status. For individuals in higher risk settings like schools or healthcare, we may exclude them from these settings until we can confirm that they are immune or the incubation period has passed. If we can identify higher risk contexts, such as very young infants, quickly after exposure, usually within 6 days, we can provide medicine and vaccine that will reduce symptoms if an infection were to occur or prevent the infection entirely. When necessary, Toronto Public Health communicates with the public to alert them to a place where they may have been exposed to measles, give these individuals a chance to review their immunizations against measles, and watch for signs and symptoms that they may have been infected through their connection with the case. Next slide. It is important to note, as I noted earlier, that measles remains uncommon in Toronto due to our high vaccination rate, particularly among young infants. Last year, there were 4 cases identified in Toronto, and the 5-year average prior to the pandemic was just 5 confirmed cases per year. So far in 2024, 3 cases have been identified in Toronto, all of them linked to travel. For the first case, Toronto Public Health conducted case management and identified 72 individuals for follow-up to prevent further spread. For the second case, exposure occurred at 2 libraries, and patrons of those libraries have been alerted to watch for signs and symptoms via a news release. TPH also conducted case management for relevant staff regarding their exposure at these 2 locations. For the third case, our investigation continues, and no public alert has been necessary, as all individuals who were significantly exposed were notified directly. I will now turn over the presentation to my colleague, Dr. Lamptey.
Thank you, Dr. Finkelstein. Next slide, please. Building on what Dr. Finkelstein just said, I'll continue to provide some information on measles vaccinations, the measles vaccination schedule in Ontario, and recommendations for reporting vaccinations in order to comply with the Immunization of School Pupils Act. There are 2 measles-containing vaccines in Canada, measles, mumps, rubella vaccine, or MMR, and measles, mumps, rubella, varicella vaccine, MMRV. MMRV provides protection from measles as well as from chickenpox or varicella. Both of these vaccines are made up of weakened live viruses. 1 dose provides, in about 85% of people, protection from measles, and 2 doses provides over 95% protection. MMR is given routinely on or after the first birthday, and a second dose of measles-containing vaccine is given at 4 to 6 years of age. Infants can receive a dose before 1 year of age when there is a risk that they may encounter measles through travel. However, if they get that 1 dose before travel in infancy, they will still require 2 doses according to the routine schedule. People can find information about the status of measles infections or outbreaks around the world through the Public Health Agency of Canada, which issues travel health notices. And these should be taken into account when traveling, especially with individuals who are not protected through vaccinations. In Ontario, measles vaccination is recommended for many groups, including children, adults born in 1970 or later, travelers, as I just noted, people who are not immune and have been exposed to a measles case, as well as healthcare workers, post-secondary students, and others. People can find more information about these indications on the Toronto Public Health website. Under the Immunization of School Peoples Act, parents and guardians must update their child's immunization records with Toronto Public Health or provide a valid exemption form. To report vaccinations, families can submit the vaccination records online using the provincial icon or Immunization Connect Ontario link, which is on our website, or records can be sent in by mail, physical mail, or fax, as indicated on our website. These methods can be used to report vaccinations, including those given or administered outside Ontario or Canada, and including records in languages other than English. Parents of school-age children do receive letters to remind them to update their child's vaccination record if it has not been completed. Next slide, please. Vaccination against measles and other vaccines listed in the Immunization of School Peoples Act declined during the COVID-19 pandemic, as we have described to this board in previous meetings. Two-dose vaccination rates for measles above 90% in our experience in Toronto are required to prevent the spread of measles and outbreaks. Since late 2023, TPH has conversed staff across the health unit to drive vaccination rates of the diseases listed in the Immunization of School Peoples Act, particularly in elementary and secondary students. This year, we are focusing on assessments of birth cohorts who correspond to children aged 7 and 17-year-olds in our publicly funded boards. As we presented earlier, up-to-date immunization for Immunization of School People Act vaccine antigens have been lower in elementary schools than in secondary schools, where the students in secondary schools have had more opportunities in the past to be assessed. For example, for measles vaccination, at the beginning of this school year, in elementary grades and publicly funded boards, 58% of students in grades 1 to 8 had up-to-date measles vaccination records on file with Toronto Public Health, compared to 86% in secondary students, grade 9 to 12. Similarly, the proportion of 7-year-olds who were assessed as not immunized, i.e. having no doses of measles on record with us, increased between 2019 of 3.7% to 16.8%, 18% in 2022-2023. So building on those numbers, if we can go to the next slide, please. This is driving the work underway to complete Immunization of School People Act assessments to increase measles protection, as well as protection from all the vaccines listed in the Immunization of School Peoples Act. Here I'm going to describe some of the work that's underway, the progress that's been achieved, including the many students who have received and reported vaccinations since our campaigns to notify parents and families, and also our school clinics that we have initiated this year. Since the start of the 2023-2024 school year, 9,400 letters have been sent out to parents and caregivers of 7-year-olds. 6,300 letters have been sent out to parents and caregivers of 17-year-olds. And 2,300 vaccinations had been administered by Toronto Public Health to these age groups since the closure of our mass immunization clinics in December. At the beginning of this effort, in the non-TDSB boards, 3 boards, 7-year-old, of the 2016 birth year cohort, or 7-year-olds, there were 4,164 students who were not in compliance with the Immunization of School Peoples Act. With all the efforts I just described, including the notifications, vaccine clinics, and direct support to families, the number of non-compliant students fell to 2,132 in terms of students who received suspension orders in March of this year. And since that time, with a number of efforts, there are now 250 students that remain on the suspension list. So that's come down substantially from the 2,000 I just mentioned. And the compliance for 7-year-olds in those non-TDSB boards is now 99.6%. So I went into all that detail to show you that all the efforts that we do increase vaccination rates, but it does take the full assessment process to get the thresholds we need for health protection, particularly for measles, which is such a communicable infection. And I'd also like to add that the work of the health unit, of course, has involved universal components and support to all schools, including communications regarding the Immunization of School Pupils Act, contact with principals before the issue and suspension periods to let them know about the upcoming actions and response. But there's also included an equity-focused approach with additional support to priority schools who are offered enhanced education and awareness for staff and parents, as well as the placement of targeted phone calls to parents of guardians of students at risk for suspension, to let them know how to come into compliance, where to access vaccines, and how to access more information through Toronto Public Health's website and immunization line. With that, I'm going to turn over back to my colleague, Dr. Finkelstein.
Thank you, Dr. Lampy. Schools do move through the ISPA process to show increased coverage rate. I think we're going to the next slide. Thank you. And so one of the key areas of response for the public health unit is to raise awareness of measles and the potential for prevention of this infection. So there are a number of strategies that Toronto Public Health employs to raise awareness of measles, which you might be aware of recently. So we've issued a number of news releases triggered by the arrival of some cases that are travel linked. We use our social media platforms. We send letters to people who have been exposed to ask them to review their immunization history and to contact us. We've communicated with counselors as well, and we have now regular web updates to provide information to the public who are looking for information about this disease. You can also see on this slide some examples of material that we have produced that have been sent around to various stakeholder groups, including the school system, to raise awareness, particularly of the link between measles and travel. We know that, as I said earlier in the presentation, that measles is increasing in a number of countries, which may be a place of exposure for individuals who are traveling. So we wanted to raise awareness of this, as we know that many people travel during the March break. So we circulated information to our school system to make them aware that there was the potential for being exposed to measles during their travels, to provide an update on their signs and symptoms so that people could be aware of coming home, to watch for these signs and symptoms, and also that there was ways of protecting themselves from measles before leaving, that vaccination is an important way of preparing for travel, and people as young as 6 months of age can get the vaccine. Next slide, please. And so in conclusion of the presentation, we wanted to raise the awareness of the importance of, as my colleague Dr. Lamptey indicated, of collecting information about those who are vaccinated and those who are not. And one way that other jurisdictions collect this information is by having a comprehensive vaccination registry. And so this registry, which it would collect information on each person who is vaccinated, so that this could be a place for us to look for people's vaccination status should they become exposed to the vaccine. And so the best way of collecting that information comprehensively is to establish a registry at the provincial level. And in the past, Toronto Public Health has put forward recommendations to the province to establish a comprehensive vaccination registry. And so at the end of this presentation, the medical officer is putting forward the recommendation you can see on the slide. Thank you.
Is that it? Okay, thank you so much for that presentation. We do have one deputant on this item, and then we're going to go on a short break after that, or recess, I should say. Skylar Hill Jackson, 5 minutes to depute before the board. Go ahead.
May I have the overhead, please?
Just put your sheet down on the platform. Okay.
In a 2011 measles outbreak in Quebec, where over 95% of the population was vaccinated, 50% of those developing measles had received 2 doses of measles vaccine. After the Disneyland measles outbreak, it was found that 73 cases of measles were due to viruses from the measles vaccine. As I understand this, if you or your child get a measles vaccine, you or your child could actually get measles from the vaccine. Studies also show that vaccinated children are shedding the virus they have been vaccinated with. A Global Health Denmark professor states, nothing suggests that these outbreaks were caused by the few who declined a measles vaccine. A substantial proportion of cases occurred in people who had been vaccinated, so the outbreaks were mainly the result of vaccine failure rather than vaccine hesitancy. Pharmaceutical giant Merck introduced its measles vaccine in 1963, claiming the vaccine would convey lifelong immunity equivalent to a natural infection, with health officials promising that 55% vaccine coverage would produce herd immunity sufficient to eradicate measles by 1967. People born before 1963 who got natural occurring measles have lifelong immunity. And by the way, all those who were part of the recent measles outbreaks now have lifelong immunity. Leading scientists of the day who first isolated measles warned against introducing a vaccine unless it provided lifelong immunity. Measles, they cautioned, would rebound with increased virulence and mortality as the vaccine forced the evolution of more virulent strains and shifted outbreaks away from children who are biologically evolved to handle measles to the elderly who could die from pneumonia, as well as young infants now unequipped with maternal immunity. A 1984 Johns Hopkins University study predicted that Merck's population-wide experiment would increase measles outbreaks by 2050, when the last generation subjected to natural immunity died off, compared to the pre-vaccine era. This is exactly what happened. Merck's vaccine, with a growing failure rate, has been incapable of abolishing the disease. Vaccine failure has left millions of adult Californians effectively unvaccinated, and 79% of people affected by measles in the 2019 California outbreak were adults. When eradication predictably didn't materialize and measles attacked fully vaccinated populations, Merck simply moved the goalpost, saying that herd immunity required 75% vaccination, then 85%, then 95%, then 98%, and now 99%. To distract the world's citizens from its failed vaccine, Merck started blaming anti-vaxxers. The MMR vaccine contains live viruses which can infect, harm, and even kill the recipient, especially if the child has an unknown immune deficiency. There are extensive warnings on the MMR vaccine information sheet about who should not receive the vaccine. Fact, the measles vaccine was introduced in 1963 after the mortality rate declined as low as 0.2 in 100,000. Fact, the largest historical decrease in morbidity and mortality caused by infectious disease was experienced not with modern antibiotic and vaccine era, but after the introduction of clean water and effective sewer systems. Fact, Toronto children receive MMR vaccine at 12 months old, and because the MMR does not provide lifelong immunity, Toronto children get another MMR shot at age 4. Shockingly, this shot not only contains measles, mumps, rubella live viruses, it includes the chickenpox virus too. 4 diseases in one shot. Fact, never in the natural world would a child catch all of these diseases at one time. Question, are these routine childhood shots overwhelming and perhaps compromising a child's natural immune system? Is this why there is a failing state
Final
of
thoughts, please.
Toronto's children's health today? And finally, there are no double-blind, placebo-controlled safety studies on the MMR
Thank you.
vaccine.
Any questions for the deputant? Seeing none, thank you. We're going to take a recess till 11:15. Okay, thank you.
Yeah.
Mr. Chair? Mr. Chair?
Hi, Councilor Thompson. Councilor Thompson, you have my attention. Go ahead.
Mr. Chair, can you hear me? It's Councilor Thompson.
Yes, we could. Yes, we can. Yes, we can. This is my Obama moment.
Oh, there it is. Sorry about that.
Councilor Thompson, can you hear me? Oh, boy.
Speak to the chair. Mr. Chair, Councilor Thompson, can you hear me?
We can hear you. Go ahead, Councilor Thompson. Okay, we're gonna, give me a second. Okay, it's now 11:15. We're going to resume our meeting. Councilor Thompson's trying to get hold of me here. Can you hear me, Councilor Thompson? Councilor Thompson, can you hear me? Okay, okay, Councilor Bravo has questions for staff. Go ahead, Councilor Bravo.
Thank you, Chair, and thank you for the presentation. One of the things that jumps out at me is recently with the measles outbreak, in the public discourse, there's been some blaming of migrants, and my own experience is that I have a giant immunization mark here, that when we come to Canada, we are vaccinated. Can you comment on the misinformation, or is this a concern that migrants are being blamed for the measles outbreak when there is references to contagion abroad?
Thank you for the question through the chair. That is unfortunate to hear. I think that what we're trying to raise the awareness is that this virus, which happens to be rare here, is not rare elsewhere, and that as people travel, there is the risk of them being exposed. And so it's an important thing to think about when people are readying for travel, that there is a way of protecting people so they get vaccinated, so that we're focused on there is a risk outside of the country. There is a risk here of people traveling to the United States can also be exposed. So we know that measles is uncommon here, so that the risk tends to be higher when going to places where the virus is more common. And that's why we're raising the awareness of the link between the virus of vaccination and travel.
So it's people who live in Canada who have a vaccination easily available to them, who are not vaccinated, who then travel, are exposed and return, creating challenges here. Is that correct?
That is correct.
Okay, thanks. I just wanted to put that on the record because it's a very dangerous narrative that's growing out there. A lot of the proactive public communication so far in measles has been in relation to travel exposure. And I'm just wondering if there's public communication and development for the general population. Particularly any thoughts on how to take a second look at the measles fact sheet, which it might need given the situation that we're in, might benefit from a look at in terms of accessibility or whether it's actually communicating the message.
So through the chair, we're constantly trying to evaluate our messages and our fact sheets, so we'll certainly take that feedback under advisement and have a look at that.
Thank you so much. And then finally, it's great to have the update, particularly of interest to me, is the work that's being done with schools and school boards. Absolutely crucial, and appreciate seeing that in the presentation. In terms of what a public health response would look like, if there is evidence or evidence emerges of community transmission of measles, Can you just comment broadly of what that might look like? So just to give the public some comfort that we are knowledgeable and prepared to respond should there be community level transmission.
Thank you for the question, Councillor, through the chair. Measles outbreaks in Toronto are rare. We have had a couple of cases of community transmission in the last 15 years, in 2008 and 2016 or 17. So Toronto Public Health does have an experience with raising the awareness in the public because the virus is starting to circulate here. That is an uncommon situation. At that point, we certainly want to increase people's access to vaccination because we know that's the #1 way of reducing the risk of further transmission is get people vaccinated. Using the epidemiology of the particular circulation of the virus that we would see, we would tailor the message to the particular cohorts that are at risk. So in 2008, when we had the last significant measles outbreak, we know that it was adults in the middle of their adult lives who might have missed having the vaccination when they were young. That was a key part of the outbreak. And so we increased awareness in that area of the population. We held vaccination clinics in areas where we saw the circulation of the virus so people had easy access to the vaccine, and that was an appropriate response to that situation. So really knowing how the virus is circulating, if it was to start circulating here, is an important contribution to our response. But I think we have the experience of those past times when the virus was circulating to be ready in case that happens again.
Thank you. That will give the public great comfort.
Director Zhao, go ahead.
Great, thank you for the informative presentation. For members of the general public who will be traveling, where do you recommend that they go to look for good quality information about measles endemic areas?
Thank you for the question. Through the chair, travel advisories are issued by the federal government. There is a web page that lists the travel advisories that are out for each country. So I urge people who are going to a particular part of the world to seek information through the federal travel web page.
And the second question I have is a lot of patients are now asking their family doctors for serology testing because perhaps they don't know if they've been vaccinated or they don't know their own immunity. Are you recommending family doctors to do serology testing for these patients or to just recommend a vaccination directly?
Thank you for the question through the chair. I think that for most people, immunity testing is unnecessary. There's getting a vaccine when you've had a past vaccination is not a risk. The vaccine can be given to people who've been previously vaccinated. We do give the vaccine to people in multiple times. So I think if there is an uncertainty, if you're traveling into an area where you believe that you're going to be exposed, I think it's important to just get a vaccine to be sure of your protection.
Particularly for vaccine hesitant people, just like a lot of the deputants that we've seen today, in terms of how we can educate them about vaccinations or whether there are certain harms to the vaccinations, perhaps they may not want a measles vaccine. Would you recommend serology testing instead?
Thank you for the question through the chair. I think as Dr. Davila mentioned in her presentation, I think the most important relationship and where people can get vaccine information is through their healthcare providers. We know that the trust that builds up between patients and their healthcare providers is fundamental to receiving that information in a way that's going to prompt action to get vaccinated. So I think it's very important for people to seek information about measles vaccination from their healthcare providers.
Great, thank you.
Thank you. Any further questions? Trustee Sriskandarajah, go ahead.
Thank you, through you, Mr. Chair. Thank you to staff for the presentation. As you can imagine, this has set a lot of fear into a lot of parents at the school board. We're getting a lot of outreach on just sort of the misinformation, and they're seeing stories in the media, and they're not sure how to react. So I think this is very helpful, and I'm sure I'll bring this back to the board. A couple of questions I've been getting asked from parents is that will the vaccine ensure that children will be protected? So these are parents who have their child vaccinated, but they're still fearful that their child will get sick.
Thank you for the question through the chair. So we're very fortunate that 2 doses of measles-containing vaccine, whether it's the MMR or the MMRV vaccine, gives very high levels of protection, likely over 95%, close to 100%. That being said, no medication or preventive medication is ever 100%. So there are what we call vaccine failures. They are rare. When they happen, people tend to get a more mild course of disease, and they're less able to transmit it. So it does provide a high degree of protection and also reduces the chance of the complications of measles, such as measles encephalitis, which is very clinically serious.
Thank you. And for the early on kids or students, children, they don't get their second vaccine until they start kindergarten. So are they at an increased risk? So they have the one, but they haven't gotten the second
dose. Through you, Mr. Chair, yes, as you pointed out, currently the 2-dose schedule does have the second booster at 4 to 6 years of age. That being said, the 1 dose of measles-containing vaccine has very high levels of protection, over 80%, close to 90%. And of course, we always look at things in circumstances. So for example, if there was an exposure in a setting with a person who only had 1 dose, through the contact management that Dr. Finkelstein was stating, we would offer a preventive second dose to someone who was a contact of a measles case to increase their protection and lower their chance of getting the disease. Thus far, the 2-dose schedule, when it's done on time, has provided high degrees of protection in our population.
Thank you. Sorry. If I understood that correctly, through you, Mr. Chair. So if they do get sick, you can get the vaccine while you're sick?
If you have, through you, Mr. Chair, if someone has been exposed to measles, to someone who has a confirmed case of measles, as Dr. Finkelstein mentioned, there is a short window after exposure where we can give a dose of vaccine to someone who has not had 2 doses to basically prevent them from coming down with the disease. It is a fairly time-limited window. It's within a few hours to days, so which is why our contact tracing efforts are so important, to find those people and offer them that protection quickly. However, because it's such a short window, the best course is for people to get their doses on time, so then that's not a concern if there is an exposure.
Thank you. I think that's really helpful for parents and just the public in general to hear that there are options and it's not too late, so to keep vaccines on top of mind. I think there's a lot of conversations about that. I just want to thank Councillor Bravo about the question about travel. That's something I thought was really important I wanted to address as well. Just a little bit more on that question. Is the issue of areas where they're getting exposed to measles just an issue of those countries have lack of access, or do countries vary in terms of mandating measles vaccines? And then what role does vaccine hesitancy play in other countries? Because I know, Doctor, you mentioned the U.S., exposures in the U.S. So do they not have a mandatory measles vaccine requirement, or is it more hesitancy? What's driving this?
Thank you for the question. Through the chair, so the epidemiology of measles in the world is very complicated. In some countries, the vaccine is not as popular, or there's less uptake of the vaccine, and so that leads to increases in the virus circulation, and so people who travel there can be exposed. In other parts of the world, such as the United States, they're suffering or have occurrence of the same situation we have, where they have importations of measles from other countries where it is much more common. And so there you do see some small outbreaks of measles. So there is the potential being exposed in the United States, but many of the United States have requirements just like we do for a school entry for vaccination. So there you're seeing the phenomenon of importation, just like it's happened here. But there is a very wide uptake of the vaccine in other countries, and that's why you see the virus circulating in some parts of the world.
Thank you.
Okay, thank you. Time. Any further questions from other directors? No, I do have two. So back to the March break and people traveling. What is the incubation period for measles?
So the incubation period for the measles is between 7 and 14 days. It averages around 10 days.
So I guess March break was about a week ago. So do you suspect we would see some results of an increase in the next maybe couple of days as a result of the March break and people not being immunized, or some people anyway?
Always very hard to predict the carry forward of the large number of people who do travel the March break. But from a perspective of incubation period, we are coming into that period when if somebody was to have become infected during their travel at March break, we would start to see those cases. Okay.
And do you think it would be helpful to have electronic immunization records rather than the paper one we currently have?
Thank you for the question. Yes, I think it's been shown in many jurisdictions that do have access to a comprehensive vaccine registry, that this is a great tool for follow-up when a case does occur, because we can rely on that to understand who is protected, who is not, in a much quicker fashion, and focus our efforts on the people who are susceptible. And so in the past, Toronto Public Health and the Board of Health has called on the province to establish a comprehensive vaccine registry, which is a great tool for response.
Okay, thank you. Those are my questions. Speakers? Anyone? Okay, I do have a motion. Staff will put on the screen. Again, it's in relation to the establishment of a provincial electronic immunizations registry. We made the same request before, back in 2022, HL 36.3, making the same request. So we're doubling down and asking the province again for an establishment of the registry. Any questions of directors, speakers? Okay, I'll move it. All those in favor? Opposed? Carried. Do I need to move as amended? No, you're okay. Okay, we're good. Okay, the next item. Second. HL 11.3, Implementation Panel for Our Health, Our City, Mental Health, Substance Use, Harm Reduction, and Treatment Strategy for Toronto. Ask Dr. Davila, you want to introduce the panelists?
Thank you, Chair. And yes, we do have we have a presentation for you, and we're being joined by some staff here from Toronto Public Health. Let me start off the presentation first by thanking the board for the opportunity to bring forward this update on Our Health, Our City, a mental health, substance use, harm reduction, and treatment strategy for the city. You will have heard about this before. It is a comprehensive citywide 5-year plan that includes a series of recommended actions for addressing the full spectrum of both mental health and substance use concerns facing the city. Given the broad base of this strategy and the fact that it is addressing this full spectrum, you're not surprised, I'm sure, to hear that it is indeed a multi-pronged, multi-sector, multi-partner approach. And you will hear more and more about this over time. But as part of our update today, you will hear about our proposed approach for this year, the first year of the 5-year strategy. And this includes the establishment of an implementation panel to help guide the work that's outlined under the strategy itself. The important part, of course, about this panel, amongst many other things, is that it will provide the opportunity for us to hear directly from individuals with both lived and living experience of substance use and mental health challenges and illnesses. And it will, of course, allow us this opportunity to continue to build upon the momentum that we've created through the extensive community engagements that were conducted in the process of developing the strategy. In today's presentation, you will also get a brief update on the current status of the drug toxicity crisis, which unfortunately continues to affect our city and is one that is rapidly evolving. We did unfortunately have to issue a second drug alert of 2024 just recently in relation to a spike in drug toxicity deaths and an observed increase in troubling new substances that we are seeing circulating in the unregulated drug supply. My colleague, Dr. Shavita Paddy, who is one of our Associate Medical Officers of Health, will walk us through some of the latest reports and data in respect of the drug toxicity crisis. Next to her, you see a familiar face, Upala Chandrasekhara, one of our directors. She is responsible for our strategy and clinical services team. She will provide some updates on the interdivisional table and our year one implementation priorities under the strategy. And last but not least, next to Upala is Sana Imran, one of our associate directors at Toronto Public Health with responsibility for clinical services. She will provide an update on clinical services and programs available at Toronto Public Health relevant to this area of practice under public health. And finally, I'll conclude the presentation with a recommended plan in respect of the Our Health, Our City implementation panel, the primary substance of the report that is in front of the board today. So with that, I will turn it over to Dr. Paddy to get going with the rest of the presentation.
Thank you, Dr. Davila. Next slide, please. So good morning, everyone. Today, I will be providing you with an update on the drug toxicity crisis in Toronto. This first graph here that I want to show you demonstrates the monthly number of suspected drug-related deaths, as well as the confirmed and probable opioid toxicity deaths in Toronto from January 2020 to December 2023. From January to October 2023, preliminary data from the coroner estimates 419 opioid toxicity deaths in Toronto. This includes both probable and confirmed deaths. We do expect these numbers to unfortunately increase once the coroner finalizes all of their investigations. This is why we see a lag right now. Although there have been fluctuations, there have been an overall increase in the suspect drug-related deaths, including confirmed opioid toxicity deaths, since the COVID-19 emergency was declared in March 2020. Next slide, please. The second graph I want to show you demonstrates the quarterly number of fatal suspected opioid overdose calls attended by our colleagues at Toronto Paramedic Services since the first quarter of 2018 to the last quarter of 2023. Once again, you can see prior to the pandemic, there were fluctuations with a little peak seen in early 2019. However, after the emergency was declared in March 2020, it shows that the fatal calls attended by paramedics have dramatically increased since the declaration. And you can see there the first quarter of 2020 marked there. Prior to the emergency declaration for COVID-19, Toronto Paramedic Services attended an average of 37 fatal calls per quarter. Since the second quarter of 2020, the number has doubled to 76, and the highest number of fatal calls attended by paramedics occurred in the fourth quarter of 2021, when they attended 97 fatal calls. So just to remind you all, this is just fatal calls, not the ones that they actually reverse. So the numbers are far higher in terms of their response. In 2023, our average number was back to sort of around the 70, 72 per quarter. Next slide, please. This is a map that shows the total number of calls attended by Toronto Paramedic Services for suspected opioid overdoses in 2023 across our 158 neighborhoods in the city. The top 5 neighborhoods are within the boundaries of Roncesvalles to the west, Bloor to the north, the DVP to the east, and Lake Ontario to the south. Now, while the highest concentrations of calls are in the downtown area, I do want to highlight that this is impacting the entire city, and that Toronto Paramedic Services recently has been responding to higher than average call volumes in parts of Etobicoke, in North York, and Scarborough. And these, just for those of you who might not be able to see, the darker red color indicates higher volumes. Next slide, please. So I want to just highlight how the unregulated drug supply is incredibly unpredictable and is changing rapidly. This slide shows data from 2023 and 2024 from Toronto's drug checking service. And it shows the amount of fentanyl in fentanyl substances. So these are substances that have been submitted for testing that are known to be or thought to be fentanyl. And they're trying to determine how much fentanyl it actually contains. And you can see from the chart below, it's extremely variable. So for example, let's take March 2024. Some samples that were tested found 0.1% fentanyl, while others from the same month were composed of 14.9%. Now let's go to January 2024. Some of the samples were made up of 0.3% fentanyl, and the others were up to 83.1%. Okay, so let me emphasize that difference. 0.3% versus 83.1%. So basically, this means that some drugs have trace amounts and some have majority fentanyl. So the person actually using the substance has no idea what they're ingesting. And people have variable tolerance rates to these opioids. I want to just highlight, this is unlike alcohol, which is a regulated substance. Because as a consumer, you know your alcohol content when you purchase your alcohol, right? For example, for beer, roughly 5%. For most spirits, it's about 40%. So the buyer is aware, and they can make decisions accordingly. That's not the case here. So Toronto Drug Checking Service has also provided ongoing evidence, in addition to this, that the drug supply is constantly changing. So this year alone, we had not one, but two major alerts sent by them, and we're just in March right now. So the first alert was sent a few weeks ago, alerting us that medetomidine and dexmedetomidine, which are new tranquilizers, one improved in animals, one improved in animals and humans, that has been discovered in our supply recently. And now, just as of, I believe it was last week, they've discovered new nitazene opioids, 2 compounds that have never been seen before in our supply. And just to highlight, nitazene are known as highly potent opioids, and they have not been approved for human consumption. And it's also, they've discovered that in the irregular supply, when people think they're getting products like oxycodone or OxyContin, that is actually containing nitazene, so far more potent than what the actual regulated pharmaceutical supply would contain. And this definitely puts people at serious risk for overdose and dying from overdoses. We are extremely fortunate to have drug checking in Toronto. However, it is not readily accessible throughout the city. Owing to the constant changing supply, drug checking is absolutely an essential service, and that should be made throughout the city. And I just want to take this moment right now to thank our colleagues at Drug Checking, Dr. Dan Werb and Karen McDonald, for leading this amazing life-saving service. I just want to end off here. This crisis is unrelenting. It requires ongoing and expanded clinical supervised consumption services, as well as harm reduction interventions that save lives. Thank you, and I'll hand it to my colleague, Upala.
Thank you very much, Dr. Patty, for reminding all of us the complete unpredictability of the unregulated drug supply. This is why implementing our Health Our City, the mental health, substance use, harm reduction, and treatment strategy for Toronto is so crucial. Our Health Our City makes recommendations that cover the full spectrum of evidence-based supports, harm reduction services, prevention to treatment to community safety interventions, which are all necessary to foster mental health and well-being and reduce substance use harms in our city for all age groups and all communities. This citywide strategy has 5 guiding principles and 7 strategic goals, all designed to support Torontonians living with mental health and/or substance use-related needs. Next slide, please. As directed by the Board of Health in April 2023, the Medical Officer of Health and the City Manager have convened and co-chair a mental health, substance use, harm reduction, and treatment strategy interdivisional table with leadership represented from relevant city divisions, commissions, agencies, and corporations. This table meets quarterly to ensure progress on recommendations relevant to specific city divisions and to ensure alignment across city divisions in the implementation of Our Health, Our City. This table met last Monday on March 18th. On the slide, you'll see the interdivisional table's work plan for this year, 2024. The main summary of this plan is a focus on the first year implementation priorities, which I will discuss in a moment. The table will also initiate a process of tracking to gather data and insights from across city divisions to develop the Our Health, Our City annual progress report, which is coming to the Board of Health in the final quarter of this year. We also want to use this tracking process as a way to engage with staff in different departments across the city to find additional opportunities for us to work together to advance the recommendations in the strategy. We will be sharing updates to the interdivisional table about the Our Health, Our City implementation panel, and this interdivisional table will also help support the implementation panel, which we will be discussing later in the presentation. Next slide, please. I just want to remind us of the year 1 implementation priorities for Our Health, Our City strategy. For priority number 1 on housing and shelters, representatives from the Toronto Shelter and Support Services and the Housing Secretariat discussed collaborating on approaches to generate more affordable housing. And the Housing Secretariat discussed advancements on over 20 supportive housing projects that provide essential wrap-around services and supports for vulnerable populations. For priority number 2, on the 24-hour crisis center, the Gerstein Crisis Center is still waiting to hear back on its application for funding for the crisis stabilization space. For priority number 3, we have received an update from Toronto Police Service that they're starting to engage with hospitals to think about the best approach to support people who are in crisis so that they can receive client-centered care while helping to improve efficiencies for both police and emergency department staff. For priority number 4, last year, you will all know, City Council approved the expansion of the Toronto Community Crisis Service. This is an incredibly exciting program being led by our partners at Social Development, Finance, and Administration Division. As a result of this expansion, they're currently looking to hire close to 100 full-time positions. We encourage people to share this information with their networks and for qualified candidates to apply to this amazing opportunity to support the health and well-being of our city. Those are the key updates from our strategy implementation partners. You may also recall that Toronto Public Health also had a few specific clinical priorities for year 1 of Our Health, Our City strategy. So I'll now turn it over to my colleague, Sana Aram, Associate Director for the clinical service update.
Thank you, Bala. So I'll provide an update on Toronto Public Health's clinical services as related to Our Health, Our City. A priority of ours is relocating the Works, our supervised consumption service and needle exchange program. As you're all aware, City Council approved a real estate strategy that involved selling the Toronto Public Health building at 277 Victoria Street, and the building was purchased by Toronto Metropolitan University. Toronto Public Health and the Works program has provided clinical and harm reduction services from this building for over 30 years. And so we are working with Create TO and Modern TO on the relocation of the Works. They have been supportive partners who understand the importance of moving our program in a timely manner and ensuring there are no disruptions to our clinical services. And then once the site has been identified, Toronto Public Health will submit a new exemption application request to Health Canada so that we can operate our supervised consumption site at the new location.
This will involve conducting community consultations and engaging with stakeholders, with residents, with businesses and service providers in the neighborhood. Toronto Public Health is prioritizing the continuity of client-centered care during this transition period by keeping services at the works fully operational and ensuring the continuity of client care during the transition period is also of utmost importance. Therefore, we are working with Create TO and Modern TO to consider interim short-term location options while we also work on finding a long-term permanent location. Adding to that, we're also hopeful for funds that would allow us to expand our hours of operation in the new space. Currently, we are open from Mondays to Saturdays, 10 a.m. to 10 p.m., and Sundays, 10 a.m. to 6 p.m. As Dr. Patty highlighted earlier, the need for supervised consumption service only continues to increase, and we have been exploring if and how we can expand our hours. This, of course, depends on funding and the new site that we secure. Additionally, we also trust that our funding request to Health Canada for our treatment program, IOD, our injectable opioid agonist treatment, will be extended. We have been funded for 2 years, and this is a well-accessed and really considered an essential service at our clinical site. It provides an alternative for clients who have not been successful using oral opioid agonist treatment options. So we are currently waiting for an official announcement from Health Canada's Substance Use and Addictions Program regarding our application. Lastly, we're also expanding our outreach capacity at Toronto Public Health and our ability to provide primary health care by initiating a new pilot program, the Downtown Core Team, and I'll ask Upala to speak more about this proactive outreach initiative. Thank you so much, Sana. And I want to give a very special thanks to the incredible and dedicated staff team at The Works for their phenomenal life-saving care they give every single day to support those who are using drugs in our community. Next slide, please. One of the main challenges that we have observed is that our clients need access to routine primary health care. This is not new information. We know that there's a massive shortage in primary health care across Toronto, across the province, and right across the country. And this issue has also come up in conversation at the health and homelessness table that Councillor Bravo inquired about earlier today. Research evidence also indicates that people who use drugs are routinely screened out of primary healthcare services due to stigma, discrimination, and due to the complexity of the care that they require. To help address this issue and to better support our clients, Toronto Public Health is piloting a primary healthcare clinic led by a nurse practitioner. This nurse practitioner clinic will be supported by a team who will be doing outreach work in the downtown core of Toronto. Hence, the name of this initiative is the Downtown Core Team, or the Downtown Community Outreach Response and Engagement Team. This outreach initiative is led by public health nurses with support from the neighborhood community officers of the Toronto Police Service. This outreach and nurse practitioner team is a 1-year pilot program, and we will be working closely alongside existing partners and initiatives already underway in the Yonge and Dundas area. This includes the Downtown Yonge Business Improvement Area, Toronto Community Crisis Service, the Gerstein Crisis Center, Cadillac Fairview, Street Health, Toronto Metropolitan University, and Unity Health Toronto, specifically St. Michael's Hospital. This pilot program works to advance key objectives of both the Our Health, Our City strategy, as well as SAFE-TO, which is the Community Safety and Wellbeing Plan for Toronto. This is a proactive outreach initiative. It is not an emergency crisis response deployed by 911 or 211. The main objectives of the Downtown Core Team pilot is to reduce vulnerability and emergency calls for service by increasing access to health and social services for marginalized individuals. There are many reasons why we're piloting this program. We know that community safety and well-being challenges across the downtown core and transit system are a prominent concern for healthcare providers, public safety professionals, businesses, community members, and residents. Vulnerable individuals experiencing an intersection of health and mental health challenges, substance use, and lack of housing are contributing disproportionately to the volume of calls for service and attendance to city staff. This pilot will allow us to offer valuable outreach outside of the physical clinic space to support health and community safety in the Yonge and Dundas area. With the new tranquilizers and contaminants found in the drug supply that Dr. Patty spoke about earlier, it can be hard to tell whether an individual is sleeping or if they have been experiencing a life-threatening overdose. With this pilot program, we will now have a dedicated nurse practitioner and a dedicated outreach team who are specifically trained in trauma-informed approaches that can ensure that community members in the downtown core of Toronto are receiving the supports where they're at. Those are all of the year one program updates for the Our Health, Our City strategy, and I'll now turn it back over to Dr. Davila.
Great, thank you very much, and thank you, Dr. Patty, Upala, and Sana for those important updates. And now, on to the next component of the presentation, our recommendations in respect of striking the Our Health, Our City implementation panel. As you may recall, the board directed us as Toronto Public Health to establish an implementation panel in order to support this strategy. It's recommended, as you will see in the report, that this panel not be a consensus-based table and that all advice from the panel be shared here with the members of the Board of Health. The recommended responsibilities of panelists, again, on this panel are indicated on the slide in front of you. And as you'll see, the main tasks of the various panelist members will be to provide advice on the annual implementation priorities, to share data and knowledge, to foster collaboration, support recruitment for additional consultations, to champion action on the strategy's recommendations, and to provide feedback on the annual strategy progress report. You may recall that a guiding principle in the development of the Our Health, Our City strategy and its implementation is the meaningful inclusion of people with lived and living experience. You'll note that there is a strong focus of that inclusion for this particular panel membership. The participation of people who use drugs and people with lived and living experience of mental health challenges and illnesses, as well as frontline service providers who work with these communities, is welcome and absolutely encouraged. We need all these voices in order to be successful. Next slide, please. On the slide, you'll see an outline of the proposed terms of references and recruitment process for the Our Health, Our City implementation panel. It is recommended that the Board of Health appoint a director from this board to serve as the Our Health, Our City implementation panel chair, and that the panel includes 6 individuals who identify as having lived and living experience of substance use and/or mental health challenges or illnesses, with at least 1 youth representative, as well as 6 leaders from community agency, health, or research sectors. We also have recommended that 6 representatives from the following citywide boards and/or city divisions be invited to join the panel. This includes Social Development, Finance and Administration, Toronto Shelter and Support Services, Toronto Community Housing Corporation, Toronto Employment and Social Services, the Toronto District School Board, and the Toronto Police Service. The panel will meet bi-monthly in person or online in hybrid meetings, and those who identify as having lived or living experience will receive a $50 stipend for each meeting attended. So we're hoping that this will meet with the board's approval, such that once we have that approval, we can begin the application process this Wednesday, March 27th, with the application portal active for a 3-week period of time. It's recommended as well that a team comprised of the Our Health, Our City implementation panel chair, myself in the capacity of medical officer of health, and another member of the Board of Health review and select nominees for appointment. Nominated candidates will be brought to the Board of Health for consideration and appointment in the 3rd quarter of this year, with the goal of launching the panel immediately thereafter. And the final slide. We do hope, of course, that we are able to have applications go live this Wednesday, the 27th, and the 3-week period of time would see those that application window open until April 17th of this year. If potential candidates require additional assistance with their application, we have made arrangements such that they can email us to help set up alternative ways so that they can provide their information, whether that's over the phone or through video conference call. You know, our goal is to make it doable for people to manage through the application process. So members of the board, I will thank you once again for your time today. There are a series of us to help answer questions, should you have any, and we'll look forward to the conversation. Thank you, Mr. Chair.
Yes, thank you, Dr. Davila and team. Amazing presentation. We do have one speaker on this item. Ingrid Boudet, are you here? Okay, she's behind you. You have 5 minutes to present to the board. Okay, go ahead.
Just waiting for it to come up on the screen.
Staff is coming to assist.
Oh, hi.
Might be an extended display.
Okay. So let's give that a try here.
Yeah.
There we are. Oh, no. Oh.
It's okay.
Excellent. There we go. Thank you so much. Okay, well, good afternoon, or good morning still, I think. Thank you to the Chair, Chair Moyes, to the City, and to the Board of Health for the opportunity to speak and for listening to my comments. My name is Ingrid Boudet, and I'm the founder of No More Noise Toronto. I have a background in process design, data, and IT. I have founded this group over 1.5 years ago after I learned that I'm not the only one who's experiencing significant health issues due to noise. I've created a data-centered approach around to understanding noise that we live with by measuring sound from people's homes with meters for over 2 years and collecting crowdsourced, not 311 noise reports to fill the gaps that exist in the 311 reporting process. We are a group that's interested in collaborating with city divisions to make for a healthier Toronto by reducing noise pollution. So let's just start off by the definition of noise. It is unwanted and/or harmful sound. So how does noise pollution fit with our Health Our City? Well, you have 7 strategic goals, and I believe noise applies to 2 of them. Number 4, advance community safety and well-being for everyone. And number 7, proactively identify and respond to emerging mental health and substance abuse issues. Noise may seem a little bit outside of the box, but I'll tell you why I believe it fits. Number 4, people who live with vision loss, for advancing community safety and well-being for everyone. People who live with vision loss, noise muffles the cues they need to navigate. They should be able to navigate the city without fear and have safe and accessible journeys. People that have cognitive impairments, aggressive, sudden, and loud sounds trigger our fight or flight response and can cause adverse reactions. And everyone should be able to walk our streets without being assaulted by loud vanity noise from cars and motorcycles. Our homes should be a place of rest and recovery. Some are exposed to amplified sounds of all hours, which they have no escape from. I have produced a noise vulnerability map with my senior geography student from University of Toronto. We overlaid household income from StatsCan, household ownership from StatsCan, and also a racial marginalized index. And we overlaid that with a dissemination track. So you can look at that at your leisure later on. Number 7 is your strategic priority number 7 is proactively identify and respond to emerging mental health and substance issues. Well, urban noise is the number 2 urban environmental health hazard. Dr. Tor Oyamo expects that it may come to be number 1 because we are doing much more to manage air pollution than we are to manage noise pollution. And from the own Toronto Public Health study, How Loud is Too Loud in 2017, 93% of residents are above the World Health Organization's nighttime guideline of 45 decibels. 54% are exposed to noise above 55 decibels at all hours. And I'm sure many of you are well aware of the health impacts. So my story, which I haven't been able to share all that often, is that I've lived in the same location for 10 years. I started to notice vehicle vanity noise, as I call it, in 2019, adding to motorcycle noise. After the first month of the pandemic, drivers discovered the empty streets, and I was kept up or woken up until 2 and 3 in the morning. This started my noise journey. In the summer of 2022, my employer wanted me to return to the office with a 1-hour commute. I couldn't do it. I had to quit, and I decided to deal with noise pollution. I have no escape from the vehicle noise in my condo. It is present everywhere. This has resulted in substance abuse, medications, constant emotional management, chronic fatigue, increased depression, and anxiety. And I'm not alone. Many other people are being involuntarily exposed to a harm, and many are suffering and tell me of their frustration, chronic fatigue, and reduced quality of life. They've increased their medications and substance abuse. They're pushed further to the edge versus being supported. If they're trying to recover or reduce drug dependency, noise makes it even more difficult. And those with mental issues and or challenges are more impacted. Many feel absolutely hopeless. So I am so glad that you have our health, our city, because we don't have a healthy city without our health. And we need to have a meaningful inclusion of people with lived experience. Involve people who are impacted. I've heard from many that they have creative, inexpensive solutions to reducing noise. Involve people living with vision loss, brain injuries, and cognitive illnesses. They have needs and perspectives that must be addressed. Noise bylaws should protect people's health. For example, reduce the number of exemptions that are allowed, and stop prioritizing other things like expediency or traffic flow over our health. And then review, of course, the recommendations from the noise control plan created in 2019. And finally, many of you may have heard, I would like you to make noise pollution a strategic priority for 2024 to 2028. And reducing noise supports so many of the city's initiatives, whether that's public health, Transform TO, Cafe TO, Vision Zero, Night Economy, Statement of Commitment to Accessibility, Streetscape Improvement Program, Strong Neighborhoods, to name a few. Reducing noise really would create a healthier and a better Toronto. Thank you.
Thank you for your presentation here today. Any questions to the deputant? Go ahead, Trustee Sriskanaraja.
Thank you for your presentation. As you saw, we are seeking public candidates to apply, so I hope you do put your application forward.
Thank you. I do have a group of over 1,200 people in my membership, and there are many people who would be well qualified and would be very willing to assist the city in this. Thank you.
Thank you. Seeing no other questions, thank you for coming in today.
Thank you, Councillor Morse.
Yeah, questions for staff on this item. Trustee Sriskanaraja.
Thank you to the presenters. That was really, and to the doctor for the very impassioned presentation. I think it really hit the issue home, especially for a lot of us who are not familiar. Just a quick question. The drug checking, is that something that's done through, Mr. Chair, by public health or through the police?
Thank you for the question through the chair. Drug checking services presently are through partner organizations. I believe the sites are at St. Michael's Hospital as well as CAMH. So we work with them. So people, clients can come to the works, for example, and submit a sample, and we work with our partners and they do the testing. And I just want to acknowledge that it's not rapid testing. So there is several business days turnaround to identify the substances.
Thank you. And through you, Mr. Chair, I know you talked about how it could be improved and that it's not as readily done. Is there any partnership with the police, with the contacts they often seize? How can we help streamline this process?
Thank you for the question. There are 3 areas where people can drop off samples. So that's at our clinic at the Works, but also Parkdale Queen West Community Health Center and South Riverdale Community Health Center. So all of those points can pick up samples that we submit to the Toronto Drug Checking Service. Does that answer your question?
Yeah, so it sounds like the onus is on the person getting the drugs as opposed to, okay. Yes. Okay, thank you. Through you, Mr. Chair, how did you come up with the stakeholders that you've decided to lean on for the community collaborations for the downtown core team?
Yes, we work regularly in partnership with the Downtown Young Leadership Table. And so there are many partners there that we've been working with over the years, and especially to provide kind of partnered outreach. And so this is a bit of a formalization of that process. So the neighborhood community officers already are on the streets in the downtown core area. There's an outreach team that the Downtown Young BIA also has, and TMU as well. And so over the past several years, we've had some outreach that we're able to do, but every time we provide outreach to the downtown core, it means that we're pulling an outreach team from another part of the city. And so that's how this kind of conversation got started. Can we have a dedicated team to the downtown core area to support the increasing needs that we've seen, especially over the last year?
Thank you. Through you, Mr. Chair, part of the reason I asked, I see that Cadillac Fairview is one of the stakeholders. Are there any local BIAs? I know, they obviously have very different experiences with this, that that Cadillac Fairview is afforded much more sort of different privileges that can be used to handle this issue. So how are we engaging sort of the smaller businesses?
That's an excellent question. So because this is very much a place-based initiative, it's really about the partners and the neighbors and the individuals in the downtown core area. Cadillac Fairview has expressed interest in supporting this partnership, whether it's through space to provide to the staff team to have touchdown in the Eaton Center or something like that. And the Downtown Young BIA, we hear updates from them regularly. So that BIA, led by Pauline Larson, they're in constant communication with the businesses. And when there's issues that come up, they're flagged to us, but also flagged to the Downtown East Leadership Table, where they're discussed and addressed.
Thank you. And my last question is, through you, Mr. Chair, if the pilot project is successful, is there plans to extend it to the Northwest? I see that that's also an area of concern, according to the map. And also, how regular will our follow-up be on sort of report back on the status of the pilot project?
We're happy to report back on the pilot project as we continue into the year. Right now, it's intended to be just very place-based in the downtown core area because we are using existing resources and dedicating them to this area. So we do not, at this point in time, have resources to expand beyond the downtown core.
Thank you so much. That's all for me.
So through you, though, Mr. Chair, should we, find some success and, hopefully we'll learn lots from this opportunity, we will then have the opportunity to come back to the board and consider what further might we recommend given the evaluation and the assessment of what we derive from the pilot. That's the ultimate goal of any pilot undertaking. We believe that we have the rationale specifically in this particular community to undertake the initiative such as it is. However, if it is successful, the real opportunity then becomes, what does that mean? You're quite right, for the rest of the city, and how might we propose further action premised on what we understand from one particular pilot?
Yeah, thank you. Vice Chair Bravo.
Thank you, Mr. Chair. I heard, was happy to hear in your presentation the importance of drug checking to prevent harm. It's a response that exists in other parts of Canada. Just wanted to ask what value you saw in, for example, the partnership in Montreal with Cactus, where you can do rapid drug testing, so you can get your drugs tested before you use them. Any value in that, being able to offer something like that in Toronto?
Thank you for the question through the chair. So just by way of background, I actually worked in British Columbia for 5.5 years in this portfolio. And what I will say, rapid drug checking has a role. It does have some evidence, But it depends on the product, the test product you're using, and the qualities of that test, right? How accurate it is. Are you getting true positives? Are you getting false positives? And so we need to reevaluate those test strips. I know some recent ones have come out testing, for example, for xylazine. Some of our colleague health units in the province are evaluating that right now, and we are closely monitoring their evaluation. But we also don't want to provide a false sense of reassurance because this is such a high risk product, right? Whereas the methods and tools used by the drug checking services, those are well-established lab methodologies. And so you're tending to get more accurate responses. So you can be fairly certain what they're identifying is actually indeed in the product, and you're not going to miss out on if, for example, you're testing cocaine and it actually contains fentanyl. So I definitely feel it has a role, but we do need to continue to evaluate and make sure we have actually good testing products for the rapid testing.
I assume that this is also a matter of budget, and obviously you don't want to give, not obviously, I'm hearing what you're saying, that it's important not to give people information that they then rely on, which could be harmful to them. However, this is an area that potentially is growing, and that it sounds like it would be a useful area to build out for Toronto Public Health if we had the resources. Is that correct?
I'll defer to my colleague for resources.
Through the chair, yes, I think that's fair.
Okay, thank you. I'll be moving a motion.
Okay. Any further questions? Okay. Deputy Mayor Morley, go ahead. Sorry.
Thank you so much, Mr. Chair. Thank you to staff for this great work. I just wanted to follow up on the question related to this new exciting pilot program. I think it's a really great direction for us to be going in, and just to sort of piggyback on some of the questions from my colleague around the evaluation measures here. I think it's really critical when we do pilots, of course, that we're really clear on what we're looking for and what we're tracking and expecting in terms of success. So I was just hoping you could speak to us a little bit more about what are those specific measures that we will be sort of evaluating and tracking through the course of this pilot project. And again, thank you for confirming, the regular report outs. That will be helpful for us to look at, but hoping you can give a little bit more color to that particular aspect.
Thank you for the question, and through the chair, we're still building out the evaluation plan. And so we want to look at both health indicators, but also public safety indicators. That's kind of the advantage we have leveraging and police data as well. So one of the key things, I'll speak from a health perspective, having a nurse practitioner clinic is a very new concept and an idea for Toronto Public Health. And so we'll be very much focused on building out that clinic. We are hoping to have a 90-day kind of case management roster. This is why we've already started to engage some key partners. We've engaged Ontario Health and, as you heard, Unity Health as well, to see at the end of that 90 days, can we find a permanent kind of medical home for some of these individuals that are currently in medical speak as unattached. They're really referred to as unattached patients. And so that's one of the indicators that we're really focusing on. We've also spoken to our colleagues at St. Michael's Hospital about the ability to be able to respond to individuals who've been admitted post an adverse event like an overdose. We know that the research indicates that between 24 to 72 hours after an adverse event, that's the moment when people are most likely to want to access treatment and other supports. And so we were imagining it kind of like, the way babies are born. After a baby is born in a hospital, a public health nurse comes to the bedside and supports the mom. We were thinking, can this outreach team with our public health nurses provide a similar process where we're reaching out to that individual who's had an adverse event, and we know because they've been admitted to hospital. And so those are some of the health-related indicators we're thinking about. But of course, our overall goal is to reduce the number of overdose fatalities, and we're hoping that this new outreach service will be able to achieve that. So we're happy to report back regularly to the board on that.
Fantastic, thank you. And I can't help but think to our my colleague again, Councillor Bravo mentioned about sort of housing and the impacts of being underhoused and sleeping rough on our streets. And so I think there will be some great alignment and hopefully some good opportunities through this pilot project to identify where we can tap other divisions of the City of Toronto and other agencies of the City of Toronto to really ensure we're getting ahead of wraparound supports for these individuals for long-term sustainable impacts. And I look forward to supporting that work. Thank you, Mr. Chair. Those are my questions.
Okay. Thank you, Deputy Mayor Morley. Seeing no other questions, I do have one or two myself. So the downtown core team, one of the things I did not see in the report was when will it commence? Do you have a timeline for that?
We're hoping to post positions in the next couple of weeks and would like to have this team up and running before the summer months.
Before the summer months, okay. And also too, you mentioned about in the presentation and in the report about the potency of fentanyl. You mentioned as well about your partnership with Unity Health and also relocation of the works. So in the last maybe 6 to 8 months, I've been touring some facilities, and one of the things that was said to me was that we don't have a lot of safe inhalation sites. So in regards to looking for a new site, perhaps, is that something that the works will try to include in going forward? Because I don't think you do that now in your facility.
Correct. Thank you for the question. Currently, we do not have a supervised inhalation service as part of our offerings. Our colleagues and partners at Casey House, they have the very first supervised inhalation room, and actually we have gone and worked with them and learned from them about really how to establish that. So we would love to have a supervised inhalation room in the new location, and that is what we're eagerly working towards.
Can you maybe remind us maybe what percentage of people who use substances that inhale these types of drugs or drugs in general?
Thank you for the question, through to you, the chair. There's an approximation that there's been a shifting dynamic in consumption patterns. So we've seen this move from injection use to now inhalation, and there's rough estimates that we're hearing about approximately 50% now are inhaling substances. So that might further explain why we are seeing more overdoses and why we might actually be seeing more use outdoors as well.
Have an exemption for injection in our space, but not inhalation. So we do see more overdose responses with our teams kind of running into the square down the street, wherever these are happening. Because it's not supervised, it's more dangerous, right? So we haven't been monitoring the person like we would inside. And so this is why we're really hoping that this outreach team will be a big support, just to check on people, because we really don't know if someone's asleep or if they're having an adverse reaction or an adverse event.
Okay, thank you for that. That's important information. Those are my questions. Okay. We'll go to speaking. Anyone, you want to go first? Or you want me to go first? You can go. Go ahead.
Thank you, Mr. Chair. I have a motion that I've discussed with staff to, well, we put it up essentially to ensure that as we're deliberating the 2025 budget, we have the information necessary to understand what would be required to expand drug checking services in all parts of the city when evidence and community needs dictate. Starting by ensuring that we have considered the cost and the possibility of the cost benefit of protecting people before there is contamination or tracking contamination with the benefit of the expert public service. I also want to thank staff for the work that's been done in the presentation, the thoroughness of it. And I think the Board of Health colleagues really captured the level of interest in the pilot, in the responses, and the continuing support of this Board of Health and making sure that we're protecting people's health, whether they're drug users or whether they're facing a mental health challenge of another nature. So thanks.
Thank you, Councillor Bravo. I do have a motion as well. Staff will put it up. And it's really, the Board of Health appoints Deputy Mayor Malik to be the chair of the Our Health, Our City Implementation Panel for the remainder of 2022 to 2026. Until a successor is appointed. So again, thank you to the team who've done so much work on this already. I know Deputy Mayor Malik was chair of the previous, mental health, substance use, and harm reduction and treatment strategy over the last beginning of the term. And the work has been extensive and well appreciated by all those involved. I'm really happy for the change that continues to take place here. And I'm feeling positive about what we're doing. And we're really helping those who are most vulnerable and marginalized in our community. So thank you to our team and to our staff for all that we do around this. So thank you again. That's it for me. Any other speakers on this item? Deputy Mayor Malik?
Thank you very much, Chair, and thank you for the nomination. I just want to be able to take a moment to speak to the item we have in front of us and our work so far. It has been a privilege and a responsibility to chair the Drug Strategy Implementation Panel this term. And I do welcome the opportunity to continue this work together with the new Our City, Our Health Implementation Panel. And while the Drug Strategy Implementation Panel is coming to a close, the work is not complete, as we have seen and heard from the presentations and the statistics and the experiences that have been shared with us. It is far from complete. And through Our City, Our Health, we will still be working to achieve the goals set out in the drug strategy almost 20 years ago, centering around the pillars of prevention and harm reduction, treatment, and enforcement as well. And I want to first and foremost honor every single person who has been part of the Drug Strategy Implementation Panel over many years. Thanks to your care and your commitment, your expertise, showing up and sharing that most important lived and living experience alongside city staff and service providers has been such a unique and powerful place for this work to actually land. And we have to be able to take the steps that continue to center that opportunity, those community voices, and the power of that type of table, and to be in this work alongside each other. And to have this example over the past many years gives us a foundation of good work to build on in this next effort. And I look forward to the involvement of members of the previous Drug Strategy Implementation panel in new ways as we move forward. I also want to give a tremendous amount of respect to the former chairs of the Drug Strategy Implementation Panel, former Councillor and Board Health Chair Joe Cressy, and longtime Chair and continued advocate Councillor Gord Perks. Your dedication and tireless work has set a really powerful example for how we move forward. And I also want to recognize the work of Toronto Public Health for the continued dedication and service to the issues of substance use and mental health. Of course, Dr. Davila, Upala, Vanessa, and previously Sonia have ensured that this panel's work continues to push the city forward in a better direction. And this new panel will have the additional opportunity and responsibility of addressing mental health, which is distinct and has many intersections with area of shared needs that we're building on from the Drug Strategy Implementation Panel. And I'm really pleased to see that in the panel's terms of reference, we have allowed for that distinction to be held through the opportunity to have working groups that are task-oriented and time-bound in order to hold some of those distinct considerations. The panel will work alongside the Board of Health to ensure implementation of this strategy remains a priority through the committed leadership given by Toronto Public Health and the city as a whole, alongside other levels of government and community bodies. And we know more must be done. In a city like ours, we should have what we need to thrive, and this includes, as we've mentioned here, affordable housing, access to supports, and of course, a sense of community and belonging. Again, I want to thank the chair for nominating me to be leading this panel, and I look forward to our work together to complete the task at hand. Thank you.
Thank you, Deputy Mayor Malik. Deputy Mayor Morley, I think you had your hands up. Before that.
Thank you.
Okay, we have a motion to extend. We have a motion to extend, then you have to go. Deputy Mayor, sorry. Councilor Bravo, motion to extend. All those in favor? Opposed? Carried. Okay. Deputy Mayor Morley, may go ahead.
Thank you, Mr. Chair. I will keep it brief. My colleague, Deputy Mayor Malik, I think said it incredibly well. But I'm just really proud of staff and proud of the city for this important work. As was mentioned, it's the continuation of a lot of important foundational work, and I think it's situating us to really ensure that all Torontonians have a shot to be supported and to be well in the city. Of course, we need to ensure people are okay at the very minimum, but I think when we do acknowledge the strength and resilience of the human spirit, when we wrap around communities with the appropriate supports, and we carve out a space and we ensure that there is a vision for a thriving city, which I think we've done very well here with the guidance and leadership of the team, we are really setting off or continuing on a really great foot. So I just wanted to congratulate Deputy Mayor Malik for her leadership in chairing this ongoing great work, and for everyone involved in bringing it forward. Thank you, Mr. Chair. And I'll be supporting the motions as well. Thank you so much.
Thank you. Any other questions of speakers? Okay, good. Let's put up the motion then. Okay. First motion's up and going up on the screen. Moved by myself. Okay. Okay. All those in favor? Opposed? Carried. Second motion by Councillor Bravo. Okay, all those in favor? Opposed? Carried. As amended, all those in favor? Opposed? Carried. Thank you. And the last item is item HL 11.4. Okay, no speakers, no presentations. You have a question? Okay. Go ahead, Councillor Bravo.
Just a quick question. There was not a high degree of confidence and familiarity with the Ontario Public Health organizational standards or the powers and restrictions of Board of Health members in the responses. Would there be any use in a more in-depth training session to be provided to assist directors, in your view?
So through the chair, yes, I think that's very reasonable feedback that can absolutely be followed up on in that manner, that we can provide further training. I will call attention to the fact that the Ontario Public Health Standards are actually in the active process of review, as led by the provincial government. They are the ones in charge of setting those standards. They have initiated a review process. So I think there's actually a really great opportunity as the new standards become published to update the board and new members as they come on board in respect of what the standards look like.
Thank you.
Okay. Any further questions? Seeing none, I do have speaking. Anyone speak? Okay, I do have a motion. Staff can put it up on the screen, please. And it reads, the Board of Health requests the Medical Officer of Health to work in collaboration with the City Clerk and the Chair of the Board of Health to implement measures to address opportunities for improvement identified through the 2024 Board of Health self-evaluation. I think it's self-explanatory. All those in, oh, you have a motion, okay? Yes.
Thank you, Mr. Chair. I also have a motion that I have shared with the Medical Officer of Health and with your office, and it is essentially to take advantage of the opportunity that the Medical Officer of Health has identified with the updating of the Ontario Public Health Standards, and to address the one area that where we seem to lack confidence as directors, just to ensure that we're being responsible for our own governance. So there you have it.
Okay. Any questions to the mover of any of those two motions? Seeing none. Okay. Put it on the screen. Okay. Okay. All those in favor? Opposed? Carried. Second motion by Councilor Bravo. All those in favor? Opposed? Carried. As amended. All those in favor? Opposed? Carried. Thank you. And that is the end of our agenda. Motion to adjourn, right? Okay, thank you, everybody. Thank you for staying, and it was a great meeting. See you next month. Bye.
Thank you, Mr. Chair. Take care, everyone.
Goodbye.